everyone, and welcome to today's webinar, How Cystatin C Measurement Contributes to Healthcare Equity. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Binding Site. To learn more, please visit bindingsite.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. Our speaker will answer any questions via the email address you provided at the time of registration. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speaker, Dr. Gabriella Lakos, Global VP, Medical and Scientific Affairs. Dr. Lakos, you may now begin your presentation.
Thank you for the introduction, and thank you all for taking time out of your busy day and joining me to learn about Cystatin C. I am very excited about this opportunity to talk about how to improve patient care and promote healthcare equity by using this important biomarker. My name is Gabriella Lakos. I am Vice President of Medical and Scientific Affairs at the Binding Site, a global in vitro diagnostic company. Our mission is to improve patient lives worldwide through education, collaboration, and innovation. This webinar is supported by my company, the Binding Site. The goal of this talk is to describe and define kidney health inequity. Also to interpret the recent recommendation of the National Kidney Foundation, American Society of Nephrology Task Force for the assessment of glomerular filtration rate. And also to discuss the advantages and challenges of the implementation of Cystatin C in routine laboratory use. So what is kidney health inequity? They say a picture is worth 1,000 words, and these charts speak for themselves. About 13% of the population in the United States is Black. However, among those on dialysis treatment, the prevalence of Blacks is almost threefold, 35%. Kidney health inequity means disproportionate prevalence of chronic kidney disease and dialysis treatment, as well as the risk factors for kidney disease, such as diabetes and hypertension in Black and African American populations. It also means lower access to nephrology care, home dialysis treatment, and kidney transplantation. There is mounting evidence for the link between unequal resources and opportunities and poor kidney health. Chronic kidney disease is defined as an estimated glomerular filtration rate of less than 60 milliliters per minute per body surface area, or a urine to albumin creatinine ratio of greater than 30 milligrams per gram present for 3 or more months. Chronic kidney disease is prevalent. It is estimated that more than 1 in 7 adults in the United States, which is 14% of the population, or 37 million people, have chronic kidney disease. Nearly 800,000 of those have end-stage kidney disease or kidney failure. Most of them are on dialysis, and about 1/3 of them lives with a kidney transplant. The financial burden of chronic kidney disease was estimated to be $70 billion in 2018. And it is predicted to rise further due to the demographic, clinical, and lifestyle changes in the population. As chronic kidney disease is very prevalent, chances are that you know several people who have chronic kidney disease. However, also chances are that they don't know about it. It is estimated that about 90% of people who have the disease are actually not aware that they have the condition. The most important risk factors for chronic kidney disease are diabetes and hypertension. Nearly 1/3 of patients with diabetes have chronic kidney disease. Although the incidence of end-stage kidney disease in patients with diabetes is decreasing, the prevalence of diabetes itself is increasing more rapidly, and it is outpacing the decrease. This is a major factor to the prediction that the prevalence of end-stage kidney disease will increase significantly in the next decade. Chronic kidney disease is associated with increased morbidity and mortality, mostly adverse cardiovascular outcomes, such as hypertension, coronary artery disease, or heart failure. Still, only approximately 40% of those who are at risk because they have diabetes, and less than 10% of those who are at risk because of hypertension are tested annually by both GFR and urine albumin to creatinine ratio, as recommended by the guidelines. As I mentioned earlier, chronic kidney disease is defined by glomerular filtration rate and by urine albumin to creatinine ratio. GFR is estimated, hence the name eGFR or estimated GFR, by measuring serum creatinine and serum cystatin C and using various equations that utilize either creatinine only or cystatin C or both. The urine albumin to creatinine ratio is calculated from albumin and creatinine concentration measured in a spot urine sample. I would like to point out that other urine tests like urine total protein, protein to creatinine ratio, or dipstick urine protein test are useful in kidney disease screening, but they are not diagnostic tests. The matrix on this slide shows the stages of chronic kidney disease, either by glomerular filtration rate from G1 to G5, or by urine albumin creatinine ratio from A1 to A3. This matrix also clearly illustrates why it is important to measure both GFR and urine albumin to creatinine ratio. Patients may have kidney damage and significant albuminuria, even if their eGFR is above the 60 milliliter per minute threshold. Let's take a look at the measurements that are used to estimate glomerular filtration rate. Creatinine is the most frequently used one. It is the breakdown product of creatine phosphate from muscle and protein metabolism. For this reason, it shows correlation with age, sex, muscle mass, and diet. Creatinine is removed from the body by glomerular filtration, and if the filtration rate in the kidney is impaired, serum creatinine concentration will rise. However, creatinine is one of those measurements with low index of individuality, which means that the within subject biological variation is much smaller than the between subject biological variation. As a result, population-based reference intervals have limited clinical utility, and a normal serum creatinine can actually hide kidney disease. There is an inverse and nonlinear relationship between serum creatinine and glomerular filtration rate. The serum creatinine can rise and still stay within the reference range, and therefore can hide a declining glomerular filtration rate. The example on this slide shows a 65-year-old woman with a serum creatinine of 1.1 milligram per deciliter, which is within the reference interval. When we calculate the eGFR, taking into account the age and sex, it turns out to be 56, which is below the 60 milliliter per minute threshold. Creatinine is used in several eGFR equations. Some of those are shown on this slide. The first one was the Cockcroft-Gault equation, which was created somewhat limited amount of data. In addition to serum creatinine, it included age, sex, and body weight in the equation. It was mostly replaced by other equations, the two most frequently used ones being the MDRD, modification of diet in renal disease, and the CKD-EPI, chronic kidney disease epidemiology collaboration equation. Both include age, sex, and race in the calculation. So let's go back to this figure illustrating kidney health inequity and examine the relationship with estimated GFR. Equations that use race in addition to patient's age, sex, and serum creatinine report higher eGFR for individuals who identify as Black as compared with non-Black individuals with the same characteristics. This has been linked to disparities in care, including delays for the diagnosis of kidney disease and eligibility for kidney transplantation. What is race? What is the difference between race, ethnicity, and genetic ancestry? Race is someone's identification with a group or ascribed by others on the basis of physical characteristics such as skin color or hair color. It is a social construct, and it may not and actually does not correlate with the diverse genetic ancestry of the communities. Ethnicity means shared culture and language. It reflects common values, cultural norms, and behaviors. It is also a social construct. Genetic ancestry is an objective biological information that estimates the geographic origin of a person's ancestors. It is, however, not available when the glomerular filtration rate is assessed. Inclusion of race in GFR equations really ignores the diversity, both within and among racial groups, and may contribute to systemic racism in medicine. Due to increasing concerns about the harmful effects of inclusion of race in GFR equations, the National Kidney Foundation and American Society of Nephrology established a task force in 2020 with the goal to reassess the inclusion of race in the estimation of GFR in the US population, and also its implications for diagnosis and management of patients. The task force has done an excellent job, and they have evaluated 26 different equations based on 6 attributes. These were the availability and standardization of the filtration assay, the feasibility and challenges of implementation, the diversity of the population that was included in the development of the equation, the performance of the equation compared to the measured GFR, which is considered the gold standard, the potential clinical, population health, and research consequences, and finally, patient-centeredness. They have published the outcome in 2 parallel papers in the Journal of American Society of Nephrology and in the American Journal of Kidney Diseases. They have made 3 recommendations. First, they recommended the immediate implementation in all laboratories in the United States, a new version of the CKD-EPI creatinine equation without the race variable. Because this new equation included diversity in its development, it is immediately available, has acceptable performance characteristics, and it does not disproportionately affect any group of individuals. They have also recommended national effort to facilitate the increased routine and timely use of Cystatin C, especially to confirm eGFR in clinical decision-making. Last but not least, they have encouraged research on GFR estimation and on interventions to eliminate racial and ethnic disparities. This slide illustrates the potential impact of the new equation. Based on the previous CKD-EPI equation, a 45-year-old male with a serum creatinine of 1.45, if he identified as Black, would have an eGFR of 67. If he identified as non-Black, would have an eGFR of 58. Based on the new equation, the estimated glomerular filtration rate is 61. In addition to eliminating the race variable from GFR estimation, implementation of the new equation will also help standardizing how eGFR is reported. The previously recommended and most frequently used option was showing both values. If African American, eGFR equals 67. If not African American, eGFR equals 58. Some labs have been conscious and concerned about the race variable and have chosen to report it as a range, 58 to 67. Others simply omitted the race variable and reported only one number, as if everybody was non-Black. This, however, could lead to significant inaccuracies and is not recommended. The new equation has only one output, eGFR equals 61, and this simplifies and standardizes reporting. Overall, it is expected that the prevalence of chronic kidney disease in Blacks will slightly increase and in non-Black persons will slightly decrease as a result of the new calculation. Let's examine the performance characteristics of the new eGFR-creatinine equation. On each of these charts, there are thousands of data points. Each data point represents a patient. The horizontal axis shows the estimated GFR, and the vertical axis shows the measured GFR, which is considered the gold standard, the reference value. Black line represents the line of identity. The green line is the curve fitted on the Black population, and the orange line is the curve fitted on the non-Black population. There are three numbers that you need to pay attention to. The first one is the bias. It is the median difference between the measured and estimated glomerular filtration rate. If it is a positive number, the glomerular filtration rate is underestimated. If it is a negative number, the GFR is overestimated. The other parameter is P30, which represents accuracy. It is the percentage of patients whose estimated GFR falls within 30% of the measured GFR. 30% is considered the acceptable error limit for eGFR. Finally, the correct classification refers to chronic kidney disease stages from G1 to G5, and it shows the percentage of patients who fall in the same category based on estimated GFR and measured GFR. The left panel shows the performance of the current equation, and the right panel shows the performance of the new 2021 equation without the race variable. With the current equation, all three parameters I mentioned, bias, accuracy, and correct classification, show worse performance in the Black population compared to non-Black. The new equation has corrected the overestimation of GFR in the Black population and increased the accuracy from 85 to 87%. As a result, the performance of the new equation is balanced between Black and non-Black participants. So what about other equations using Cystatin C or the combination of creatinine and Cystatin C? Cystatin C is a 13 kilodalton basic protein that is produced by all nucleated cells, and it is freely filtered by the glomeruli, which makes it a perfect glomerular filtration marker. It appears to be less affected by age, sex, muscle mass, diet, and race than creatinine. It is measured by immunoassays, and the values are traceable to the IFCC reference material. As I have mentioned earlier, the second recommendation of the National Kidney Foundation American Society of Nephrology Task Force was to facilitate the increased routine and timely use of Cystatin C, especially as a confirmation test, and to support better clinical decision making. So let's take a look at the eGFR Cystatin C equation. This graph is similar to the previous one. The horizontal axis shows the estimated GFR, the vertical axis shows the measured GFR, the black line is the line of identity, the green line is the curve fitted on the Black population, and the orange line is the curve fitted on the non-Black population. Looking at the performance characteristics, this equation is remarkably accurate. It has very low bias in both Blacks and non-Blacks, and it has a relatively high accuracy rate. This equation actually does not include the race variable in the computation, and therefore no refit was needed. It also has minimal differential bias. Differential bias is actually the difference between the bias in the Black and non-Black population. In this case, it is only 0.8 milliliter per minute. As opposed to the cystatin equation, the equation that uses both creatinine and cystatin C did undergo a refit because it included race in the calculation. The current equation, shown on the left, was very accurate to begin with. However, it had the same issue as the creatinine equation. It overestimated glomerular filtration in Black participants. The new equation, showed on the right-hand side, corrected this bias and increased the accuracy from 89 to 91% in Blacks. This 2021 creatinine cystatin equation is the currently available most accurate equation. It also has small differential bias. The results that I have shown clearly demonstrate the clinical usefulness of Cystatin C measurements, and also that the most accurate GFR estimation includes both serum creatinine and Cystatin C. Cystatin C measurement should be considered as confirmatory test in situations when eGFR based on serum creatinine is suspected to be inaccurate. Some of these conditions are listed on this slide. For example, extreme body size, severe malnutrition or obesity, muscle diseases, or vegetarian diet. It is also recommended in clinical situations when a very accurate GFR value is needed. For example, for dosing of chemotherapy drugs or antibiotics that are cleared by the kidney, or for kidney donation evaluation. Cystatin C measurement is also recommended to confirm chronic kidney disease stage G3A when the GFR is between 45 and 59 and there are no other markers of kidney damage. And also to confirm the lack of chronic kidney disease in patients who have an estimated GFR of 60 to 74. We have to acknowledge, though, that there are significant barriers for the adoption of Cystatin C in routine clinical practice. Based on a 2019 College of American Pathology survey, only 2% of laboratories offered Cystatin C assay, and 90% has sent it out. The situation has likely changed since 2019, but this data suggests that Cystatin C is not offered by the majority of clinical chemistry labs, which has an impact on both cost and turnaround time. Cystatin C is also more expensive, more than 3 times more expensive than creatinine, and requires special instrumentation because it is measured by immunoassay. Restrictive insurance coverage further limits the widespread availability of Cystatin C and should be the focus of concerted efforts from healthcare, patient organizations, and the industry. In the last part of my talk, I'm going to show some examples for the clinical usefulness of Cystatin C and Cystatin C-based GFR calculation. In one of the recent meta-analyses shown on the left side, the authors compared the performance of 7 different Cystatin C and creatinine-based equations from 26 studies for the prediction of vancomycin clearance. Creatinine-based equations demonstrated a statistically significant positive bias, 27.6 milliliter per minute, while Cystatin C-based calculations were unbiased and accurate. In another meta-analysis, shown on the right-hand side, authors analyzed 14 studies comparing Cystatin C and creatinine clearance for the prediction of the elimination of multiple drugs. They have examined the correlation between renal function as assessed by either creatinine or Cystatin C-based equations and the clearance of renally excreted drugs. 13 out of the 14 studies showed that Cystatin C was superior to creatinine to predict the elimination of the evaluated drug. Another study looked at the performance of serum Cystatin C and serum creatinine in critically ill patients in the intensive care unit, in comparison with measured GFR to predict a decreased glomerular filtration rate. Based on ROC curve analysis, serum Cystatin C clearly outperformed serum creatinine for the prediction of the GFR threshold of 60 milliliter per minute. The area under the curve for Cystatin C was significantly larger than for creatinine. Cystatin C-based eGFR equations have also been evaluated in multiple myeloma. One study compared the performance of multiple eGFR equations in newly diagnosed multiple myeloma, including the MDRD, the CKD-EPI creatinine, Cystatin C, and creatinine cystatin equation. This study found that Cystatin C-based equations identified higher number of multiple myeloma patients with renal impairment. 28.6% of patients were reclassified into higher CKD stages according to the Cystatin C equation compared to the MDRD formula. In addition, Cystatin C-based GFR independently predicted survival. If we take a look at the details, we can see that actually all equations produced similar median overall survival prediction for patients with stage 1 or 2 chronic kidney disease. However, cystatin-based equations shown in the lower panel demonstrated a significant difference in overall survival for patients with chronic kidney disease stage 3 and 5. 3 to 5. You can see how the survival curves separate from each other on the two lower graphs, showing the performance of the CKD-EPI cystatin and the CKD-EPI creatinine cystatin equation. As a conclusion, authors have suggested that routine measurement of Cystatin C could be incorporated in the workup of newly diagnosed multiple myeloma, and also suggested that the equations using Cystatin C should replace the MDRD formula in this patient group. In another study, Cystatin C-based estimated GFR was a better predictor of adverse events in the elderly, including mortality, heart failure, bone loss, peripheral artery disease, and cognitive impairment, compared to creatinine-based estimated GFR. This graph shows hazard ratios for death from any cause according to whether eGFR was calculated with the measurement of creatinine or Cystatin C or both. The hazard ratios were adjusted for age, sex, race, body mass, and other variables. This graph illustrates that eGFR based on Cystatin C, and shown in red, outperforms eGFR based on creatinine and even the combination of creatinine and Cystatin C. Cystatin C assays are available as automated immunoassays from many commercial sources and on many different platforms. The tests are standardized and the values are traceable to the IFCC reference material, although some differences between different brands have been reported in the literature. This wide commercial availability will hopefully facilitate the sustained adoption of Cystatin C measurement in routine clinical labs. In conclusion, the use of the race coefficient in GFR estimating equations is problematic and no longer recommended. The National Kidney Foundation American Society of Nephrology Task Force recommend the immediate implementation of the CKD-EPI creatinine equation refit without the race variable in all laboratories. The task force recommend the increased, routine, and timely use of Cystatin C, especially to confirm eGFR in patients who are at risk for or who have chronic kidney disease. Cystatin C is a glomerular filtration marker that is less affected by age, sex, muscle mass, diet, and race than creatinine. The CKD-EPI cystatin equation does not include race in the calculation. The combination of creatinine and Cystatin C provides more accurate GFR estimation than either marker alone. And there is emerging evidence for the superior performance of eGFR using Cystatin C measurements in critically ill patients for dosing renally excreted drugs, as predictor of adverse events in elderly, and for predicting survival in patients with multiple myeloma. I hope you find the information I have presented helpful, and you will make efforts to implement Cystatin C measurement in your own laboratory. Thank you very much for your attention. Please feel free to submit questions, and I will be answering those by email.